Hi, I'm Mikey, a Mycobacterium fituitum here to represent rapidly growing Mycobacteria, a group of non-tuberculous Mycobacteria. After Mycobacterium smegmatis, I'm the second most common RGM species found in Australia. I'm a ubiquitous saprophyte, thriving in soil, water, and decaying vegetation. I'm a rod-shaped, non-spore-forming obligate aerobe with a thick, waxy, lipid-rich cell wall. Though gram-positive, my cell wall makes staining difficult, so I'm best visualised with an acid-fast stain like Zeal-Nielsen. I can infect multiple species, including humans, wildlife, cats, and dogs. In Australia, I commonly cause mycobacterial paniculitis in cats. Let's focus on that today. My primary mode of transmission? Trauma, especially via cat scratches. Cats pick me up under their claws from the soil and pass me along in fights. I can also enter through bites, sharp objects, or surgical wounds. Like all RGM, I have a tissue tropism for fat. I need triglycerides to help me grow and evade the immune system. My perfect victims are fat cats and outdoor fighters who frequently encounter me in the environment. As mycobacterial infections are opportunistic, I don't even need an immunocompromised host, just an entry point. I infect fatty subcutaneous tissue, especially inguinal fat pads, lateral abdominal walls, and the perineum. Once I'm inside the host, the immune system sends macrophages to destroy me. But here's the catch. I survive and replicate within phagocytes, causing granulomatous or pyogranulomatous inflammation. Clinical signs include localized cutaneous lesions, including dermal nodules, draining tracts, purple pepper pot depressions, and alopecia. Tissue thickening and local lymphadenopathy are common. The wounds don't self-heal, can be ulcerated or multifocal, and may expand, but systemic infections are rare. Severely affected cats may become inappetent, lose weight, develop pyrexia, or show lethargy. Mycobacterial infections should always be considered in cats with these signs, especially in fight and bite locations. So how do you diagnose me? Cytology via FNA may reveal me with acid-fast stain, but my absence doesn't rule me out. Deep tissue histopathology is better, as pyogranulomatous inflammation often extends deeply, but morphology and staining alone can't identify my species. Culture can confirm my identity but takes some time, usually 5 to 7 days. PCR is the gold standard, fast and accurate for identifying me, but it can be expensive, so culture is often the diagnostic test of choice. Treating mycobacterial paniculitis can be tricky, but has a good prognosis if done properly. Medications should be chosen following antimicrobial susceptibility testing, but generally treatment requires long-term combination therapy with macrolides and quinolones for 6 to 9 months. Short courses or monotherapy often don't work. They increase relapse risk and possible systemic spread. Surgical debridement may be needed for full recovery. But why treat when you can prevent? Since I love soil and spread through cat scratches, preventing infection is simple. Keep cats indoors and away from feisty neighbourhood fights.